In this lecture, we'll be discussing basic EKG interpretation, and with that in mind, I want everybody to keep in mind this is certainly not all-encompassing and not including all material that could be learned about EKG. These are just the basics and some of the interesting things that you might see or note or find when observing an EKG rhythm strip. So we'll kind of begin with some basics and move forward and take a step-by-step approach in some regards, but please keep in mind that the material covered in this individual lecture is not likely enough to provide a high level or degree of competency for interpreting EKGs on a large scale. So the things that we'll cover will be of unique importance, but may not provide all of the tidbits and all of the criteria that a cardiologist, say, might be looking for on a given rhythm strip. So we'll look here first at a basic 12 lead. Now, I want you to take note of the events that are touching the red line. See, everything that occurs on this red line happened at the same point in time. You'll notice that there are these little hash marks, okay, here and here, and some more over here, and some more over here. Now, each of these hash marks indicates a 3-second period of time. For instance, this area would be 3 seconds, this area would be another 3 seconds, this area would be another 3 seconds, and finally, this area would be another 3 seconds. So we're looking at a 12-second EKG. And something that happens, let's say here, at time point, let's say 1 second, may look very different from what happens over here, nearly 10, 11 seconds later. Not to mention, what happens in this area is looking at the heart from a different perspective than what happens in this area. And so I want to highlight to you the 12 leads. Now, let's ignore everything below this imaginary line here. This would be a continuous lead, and in this case it's lead 2. You'll also notice that lead 2 is here, but it's not continuous in that it stops after 3 seconds. So in this first 3-second time frame, we're looking at leads 1, leads 2, and leads 3. In the second 3-second time frame, we have AVR, AVL, and AVF. Then in this next 3-second period of time, we have V1, V2, V3. These are our precordial leads, continued with V4, V5, V6 in our final 3 seconds. So each of these leads observes the heart from a different perspective, meaning that what happens in, let's say, leads 2, 3, and AVF might correspond to areas of the inferior heart. If we look at V1 and V2, we might be looking at areas that are closer to that interventricular septum or the septal regions. And then you can see there that we might observe some lateral or anterior perspective of the heart as well. So when a cardiologist, when a physiologist looks at an EKG or a rhythm strip in this nature, they're looking at different segments to see what areas are impacted, because that's going to give an idea of where in the heart the dysfunction may occur. And that dysfunction may be looking simply at the PQRST to indicate what part of the electrical rhythm strip is impacted, but it also may look at what part of the EKG leads 2, 3, AVF, for instance, because that gives us an indication of what part of the heart, myocardium, may be impacted. And if we know our anatomy of the heart and the myocardium, we might be better able to understand what coronary vessels may be involved. So here, our main function when we look at the electrical conduction system is to understand that we have an electrical impulse that travels from the SA node, that's our pacemaker, creates this electrical impulse, which then transmits to the myocardium. So in this example, we have the SA node that fires, traveling along these internodal pathways, perhaps across what might be considered a Bachmann bundle. Ultimately, this electrical activity propagates across both atria, the right and left. And then that signal gathers in the AV node and then propagates down this bundle of His into our right and left bundle branches, and finally with our Purkinje fibers. So it's this electrical chemical process which creates the electrical energy that's picked up by the electrodes in an ECG waveform. And so here would be our specialized conduction system. It's interwoven within the myocardial tissue. So it exists inside the heart's walls. And this figure shows the system in that this electrical activity has a pathway. And this pathway, when not disrupted, provides us with a rather standard or typical PQRST ECG waveform. However, once an electrical activity occurs outside of this pathway, or the electrical impulse is generated from somewhere that's outside the SA node, our ECG is going to look very different. So one of the things that we might highlight here is that we do have a pacemaker. And the SA node, you see there, beats between 60 and 100 beats per minute. And many of you would say, well, obviously everybody's going to be a little bit different. And so you can think of that difference as, in terms of physiology, the amount of parasympathetic tone that is acting on the heart. In other words, when you're sitting at a stoplight, you have your foot on the brake, and if you let your foot off the brake just a little bit, your car creeps forward. Yeah, SA node's very similar. If the brake is pressed harder on the parasympathetic side of things, the heart rate slows down. If you let up on the brake, or we withdraw parasympathetic tone, the heart speeds up. Now, if we let off the brake completely, our maximal heart rate typically generated from the SA node at rest is somewhere between 60 and 100 beats per minute. So although the SA node normally acts as the heart's pacemaker, every cell does have an electrical conduction system, and it has the ability to set the pace. So let's say the SA node fails. Then the atrial cells, we might have some electrical impulse generated from within the atria, or from the AV node. Or if we have the atria in this electrical conduction pathway completely fail, we might have some type of block or heart block that's present, creating a challenge for this electrical impulse to generate. Maybe we have something closer to the AV node and bundle of His that now sets our pace. So the fastest pacer is the SA node. The second fastest pacer is the AV node, if we look at our true nodes and how that pacing would occur. And so obviously we see there that the further we get down in this electrical conduction pathway, the slower the pacemaker settings. Now, when we look at an ECG, we want to keep in mind the electrical activity generated by the myocardium is really represented as a series of vectors. And vectors typically represent the amount of energy with a direction, right? So this is what makes up a vector, where we have energy and direction. Now, if we add all of these vectors up, we do a little vector math. Let's say we have two vectors going in this direction with a magnitude of 2, and one vector going in this direction with a magnitude of 2, one direction in this direction here with a magnitude of 2. If we add those together, we get 0. If we had two vectors each in the same direction with a magnitude of 2, we would get, if we added up those vectors, a large vector of 4. So if we look at all of the different myocardium that propagates during this electrical conduction pathway, all of this myocardium is sending vectors in different directions, and they all add up to this point. And so if they're all at angles that are different to each other, we have to add and subtract all the energy and then represent the general direction. Now, when we look at the electrical axis of the heart, typically it occurs down in this angle at about 70 degrees. And the sum of all the vectors that are generated by the myocardium gives us this electrical axis. Now, if that electrical axis swings to one side or the other, in other words, it doesn't stay down in this direction, this might give us some indication of some pathology that may be going on. For instance, you see there the normal quadrant. We have 4 quadrants of the hexaxial system. Normal would be down in this direction here, as we saw that figure on the previous screen. But let's say we have the vector, the electrical axis of the heart, swing over to the right side. Or it swings up over to this left axis. We have deviation that occurs, and so we would call this right axis deviation or left axis deviation, or in some cases extreme right quadrant or extreme right axis deviation. And these all give us different indications of what's going on with the electrical system in the heart. So let's take a look at a couple of axis deviations and some of the causes. Let's take, for instance, right axis deviation. If that electrical impulse, instead of being down at 70 degrees, now works its way over to 110, 120 degrees, where it's now down in this direction here, we have right axis deviation. Now, this may be normal in some adolescents and children. This may not be anything to be necessarily concerned about or worried, especially if there's, asymptomatic, there's no issues that seem to be present. Might be nothing at all. We could also have right axis deviation if we have a larger right ventricle. Think about the vectors for a moment. The vector's magnitude changes based on the size of the myocardium. A larger muscle generates a larger electrical impulse. So if the right side of the heart enlarges, it takes that normal axis and it swings it over toward that right quadrant. So in some cases, there could be a right ventricular hypertrophy. Now, we could also have a left posterior hemiblock. This would be on the left bundle branch. We have an anterior and a posterior component. And if there's a left posterior hemiblock, then all of the electrical impulse generated on the left side is fundamentally not occurring. And so if there's a push-pull between the electrical activity and this area of tissue on the heart on the left side is turned off, then there's nothing to counter the electrical impulse, and so it's going to pull further to the right because there's nothing pulling it back toward this normal. So if it's normally in a normal position, and then we have this left posterior hemiblock where the cells that are up here kind of creating this balance between cells on the right bundle branch and the left bundle branch, if these turn off, then this axis that's normal now swings over to where more of that electrical activity is occurring because there's nothing to pull it back the other direction. So it'd be a left posterior hemiblock. Dextrocardia, if we have the heart essentially transposed, then the electrical activity, instead of being normal down toward the bottom side here, because the heart would be in a sense flipped, we would have the electrical activity now more in this direction. Again, right axis deviation. And certainly if we have ectopic ventricular beats generating an electrical impulse from outside this normal conduction pathway, depending on the location of those, if those beats are occurring more so on this right side of the heart, it may swing the electrical axis toward the right side. Now, left axis deviation may occur with a left anterior hemiblock, and this anterior hemiblock is because of the location of this left bundle branch and how that left branch, or that anterior branch, covers the heart. So if that turns off, more of the electrical impulse is pulled to the left side or to the left posterior, and that's going to change, and it's going to take this normal axis and it's going to now swing it up to the left. So that would be an example of why we might have left axis deviation, or if there's ectopic ventricular beats that are generating from somewhere on this left side, that could be a problem as well. So one of the more common causes of left axis deviation is left anterior hemiblock. Okay, that tends to be one of the more common reasons, as opposed to the ectopic ventricular beats. Ectopic meaning coming from outside of the normal conduction pathway. So we look at these electrodes and these waves, and typically when we place electrodes on the person's body, if you look at an EKG and you look at the leads as you're setting them up, they're going to be positioned with certain numbers: right arm, left leg, right leg, V1, V2, V3, V4, V5, V6. And each of these is organized in a certain manner where there's going to be what's considered a negative and a positive pole. And typically when the electrical impulse travels, the positive impulse is moving away from the electrode, and it converts a downward wave. So if we're moving away from this electrode, then if we looked at this particular electrode here, it would represent a downward deflection. Whereas if we looked at this electrode here, and when I say looked at this electrode, I'm saying we're looking at a different perspective of the 12-lead ECG. If the particular 12-lead ECG that we're looking at is aimed and the electrical activity is traveling toward that electrode, the waveform is going to be reflected as positive. So I want to highlight just this understanding that because of the position of the electrodes on the person's skin, because of the way that the vectors are generated by the myocardium, this is what gives us some upward and some downward reflections on a PQRST waveform. So electrodes are essentially these sensing devices that pick up the electrical activity occurring beneath them. So we also may, in some cases, have what's called an isoelectric lead. And an isoelectric lead would be where we have kind of an equal positive and negative deflection. So if a vector is exactly isoelectric, meaning that electrical activity is kind of directly perpendicular to it, this is what would be considered an isoelectric lead. So the vector can point in one of two directions, either negative or positive, but in this case it may be equally positive and equally negative. So this maybe gives some perspective to how this lead or waveform is taking pictures. So if you recall, we had these limb leads, lead 1, lead 2, lead 3, AVR, AVL, AVF. And leads are essentially like cameras taking pictures of the heart. Various leads are placed in different positions, essentially taking the same picture from different angles. And so it gives us a three-dimensional perspective. And because of that three-dimensional perspective, we can now better understand the electrical axis of the heart. And depending on where we're looking, it may be reflected as negative, moving away from the lead, or it may be reflected, in this case, lead 2, as positive, as it's mostly moving toward the lead. In the case where it's moving perpendicular, it may be a little more isoelectric, depending on the exact electrical direction. So you heard me mention limb leads a moment ago, and limb leads are typically those that comprise the 6 leads of the 12 lead. So the 6 leads of the 12 lead would be lead 1, lead 2, lead 3, AVR, AVL, AVF. And those are created by these 4 electrodes placed on the right arm, the left leg, and the right leg. And based on the positioning of these particular electrodes, we create our first half of a 12 lead. This gives us this hexaxial system. Now, I won't go into Einthoven's triangle, which is what we see represented here. There's a little bit more complexity in terms of augmented leads. That would be your AVR, AVL, AVF. These are augmented as combinations of either lead 1, lead 2, and lead 3. And that's what we kind of see happening here. So I won't go into a lot of detail there, but the purpose of this brief discussion is just to highlight how it is that a particular electrode represents the ECG waveform as positive or negative when we see this readout. Okay. We also have precordial leads. And these precordial leads are placed around the heart, around the chest. Those create the second half of your 12 lead. V1, V2, V3, V4, V5, and then over here onto the armpit, V6. So these precordial leads give us a better perspective of the transverse plane surrounding the heart. Now the precordial leads, V1 through V6, unlike the limb leads, these must be placed exactly in the configuration shown. And there's some very specific locations such that, for instance, V1 and V2 are placed positioned side by side on opposite sides of the sternum, and we feel and palpate for the fourth intercostal space. To find the fourth intercostal space, we would isolate the angle of Louis, which is the bump near the top of the sternum, and then we feel down from the top and we can locate the second rib, and then feeling the space directly beneath that would be the second intercostal space, counting down to the third and the fourth intercostal space. And there are a number of different resources which can help you to identify and palpate these locations, but the point is the precordial leads need to be specifically placed in these locations based on our anatomical structure of the heart. V4 is typically placed at the fifth intercostal space in the mid-clavicular line, and then we would follow the diagrams here correspondingly with our anterior axillary line and the mid-axillary line as we carry around the side of the body. Now the point of doing all of this is to create these leads that circle the heart, giving us a view or a perspective of the transverse plane. So these essentially sit perpendicular to the limb leads. The limb leads, right, are these here that go in this manner, kind of creating this frontal plane. So the view of the precordial splits the body through the center of the heart into a top and a bottom half, right? And that's how we get that transverse plane. So again, recall our location of our 12 lead ECG. Lead 1, lead 2, lead 3, AVR, AVL, AVF. And then our precordials, V1, 2, 3, 4, 5, and V6. So this figure shows the placement of these various leads in a standard format on an ECG rhythm strip. They're always going to be in this configuration if we're looking at a 12 lead. Okay. There are several variations which can occur due to multiple manufacturers, but in most cases, if we look at a typical 12 lead, we can have this configuration. Some manufacturers will allow you to adjust how the leads are represented, so you can have a little more customization if you're really only concerned with a couple different ECG leads. If you're specifically looking at a different part of the heart and you want to look at all those side by side, certain manufacturers will allow you to do that. So when we look at this ECG, the ECG machine's computer is capable of measuring 3 or more leads at once. So typically, again, I mentioned this was a 3-second block of time. In this example, we would have lead 1, 2, and 3, as well as a continuous lead strip. And some manufacturers allow you to change this. In the example I showed on one of the first slides, this was lead 2 as a continuous strip. So you had lead 2 represented here, but then it stopped, and you had AVR, AVL, and AVF for the second 3-second component. So remember, all of the events touching the red line, this one here, this one here, this one here, and this one here, occurred simultaneously. So anything that happened at that point in time, you could look up or down the red line and say, what was also occurring at a different perspective. Now that means that if you saw something that happened here and you said, gosh, I wonder what's happening over in the precordial lead, you'd have to wait for the rhythm strip to print out what was happening over on this side, understanding that it may be another 10 seconds until you get to that. So if there was an ectopic beat or something that happened at a given point in time, you may not see it represented because it happened here, and 10 seconds later that problem had maybe resolved. So you want to keep in mind how you observe and look at an ECG. So again, we have these color-specific areas in this figure to represent regions of the ECG, and if we're a cardiologist, if we're an exercise physiologist, if we're a clinician who's looking at an ECG and we identify problems in a given set of these colors, it gives us an indication of where on the heart the problem may be occurring. So let's take a look at the ECG paper. Okay, so on the ECG paper, we have these boxes that are going to be small and large boxes. So if I go to this one here, you can kind of see that there are some large boxes here, and each of those large boxes is surrounding a 5 by 5 smaller box area. So the paper is broken down into, 3 or 4 strips at a given point in time, or 3 or 4 rhythms. Here I've got 3 rhythms at a given point in time. And if we look at each of these large boxes, each large box tells me there's 0.2 seconds of time in each of these large boxes. And if we look vertical, vertical is distance. So it tells me how many millimeters tall a particular waveform is. So left to right would be time, and each of these small boxes would be 0.04 seconds. So if you see some type of ECG waveform that encompasses 2 small boxes, you would say that was 0.08 seconds of time that transpired for that particular waveform. And then we would be able to look and see, if it was one big box, we'd say that lead is 5 millimeters tall. Let's see if we have an example. So if we look over here, maybe we have a lead that's about 5 millimeters tall. Here we have a lead that's maybe 10, 12 or so millimeters tall. Now, the other thing that you'll note is we also have this calibration box that's at the end of our rhythm strip. And this calibration box tells who's ever looking at it how to interpret each of those boxes. If we see this normal calibration box here, it's just as I indicated, that a standard calibration box, in this case would be 10 millimeters high and 0.2 seconds wide, okay, comprising the small boxes, 5 small boxes. And so this tells me that I'm looking at a normal rhythm strip. So all the things that I just told you would ring true. But if we had, let's say, a calibration like this, this would indicate that everything being representative is at half calibration. So if we were to look at the height of something and we saw this particular calibration box, everything would have to be doubled because we'd be looking at it in half size. So if this was being represented in half size, we would say normally it's 5, 10, maybe 11 boxes. But if we saw this indicator, instead of 11, we would say, that one's 22 boxes tall. And they may have done that because perhaps the ECG waveform was way off the screen. It was way too tall. So they had to shrink it in order for it to fit so that you could actually see what was going on. So that might be a reason there. We also might have this one, which might be a normal height, but it might be 2 times as wide. In this case, we're slowing down the paper so that everything that we see is being represented as we had something that was very large. We had to slow down the paper, and so we'd have to do our math to say, well, instead of 0.04 seconds, everything that I'm looking at on the 0.04 might be 0.02. Okay, and we might have to do that if we had a really slow heart rate that, in some cases, even if we looked at a 12-second rhythm strip, maybe we only had 1 heart rate, 2 heart rate, 3 heart rates. So we only had 3 heart rates to look at. Well, that wouldn't maybe be enough to help us. So if we slow down the paper, now instead of 3 that show up, now we have 6, but we have to keep in mind each of those is at half speed. So that might help give you more beats to look at. So here might be some examples, right? Normal calibration. So this is a normal calibration here. Okay. Here in this case we see this one's being zoomed in, and in this case instead of being half the height, it's now being zoomed in so that it's twice the height. Now why would they do that? Well, maybe they were concerned with what was happening here at this location on this anteroseptal region of the heart. And they were specifically concerned about looking at the P wave. Maybe there was something specific about the atria that they wanted to identify. But when it was at normal calibration, it was too small. So they enlarged it. So that means when we look at this and we say, oh, it's 4 boxes tall, we'd say, well, it's 4 boxes tall, but it's twice the actual height. So it's actually 2 boxes, 2 millimeters tall, if we were to actually represent the measurement. So in this case, the calibration has been adjusted to twice the height. So we have a lot of different ways that we could do this. Again, the half standard, which I talked about, this would be an example here where, if we had a full regular calibration, do you see how some of these leads, these ECG waveforms, are running into each other? So this would be a hypertensive patient with left ventricular hypertrophy. We're going to talk about some of the criteria of left ventricular hypertrophy in just a moment. But for now, I want to illustrate what happens when we create a half calibration. Do you see here now we took that same patient with the left ventricular hypertrophy and we, at half calibration, shrunk the waveform so now they don't run into each other, and now we can get a better perspective of what's happening during each individual lead. Right? So this would be an example, another example where, if we're trying to count the height of each of these R and S waveforms, it's very, very difficult to do that because they run into each other. So this one might be an example where if you were looking at this in the field, you might hit the button to say, let's calibrate at half. That way we can better identify what they are. Right? Same thing happens when you see this calibration, which we've talked about. So couple things to highlight, important kind of bullet points, if you will, would be that the SA node, AV node, bundle of His, bundle branches, Purkinje fibers, this electrical conduction pathway corresponds to the ECG waveform, the PQRST, that we see at the bottom of the screen. So when we have this electrical activity that begins in the SA node, we have this electrical impulse that propagates across the internodal atrial conduction pathways, and the atria depolarize. Now, as the atria depolarize, they functionally begin contracting. And that contraction facilitates movement of blood from the atria into the ventricles. You'll notice that in this case, we have neither up or down. We're going to call this the isoelectric line. In this case, there's no electrical activity that's occurring. The electrical impulse has paused here in the AV junction and bundle of His, this AV node bundle of His. So this electrical activity that was propagating across the atria pauses, and there's no electrical impulse for this short period of time. That's very important from this physiologic perspective. You see, that pause in electrical impulse allows time for the blood to move from the atria to the ventricles. Because if the atria contract and immediately after the ventricles contract, there may be no net movement of blood. We didn't have enough time to contract the atria, allow blood to move down the atria through the tricuspid bicuspid valve into the ventricles. Then the ventricles contract, slamming shut the tricuspid bicuspid, opening up the pulmonic and aortic valves, and sending the blood out to the pulmonary and systemic circuit. So that pause is critically important to allow for atrial kick to occur. Now, the electrical impulse and electrical activity soon continues down the bundle branches and Purkinje fibers, initiating ventricular depolarization. And that ventricular depolarization, as you guessed, much like atrial depolarization, would be facilitating activation of the ventricles, contraction of the ventricles. And that facilitates blood moving out to the lungs and the rest of the body. Now, also on this figure, you see this here. Ventricular repolarization. This corresponds to this T wave. Right? Because stay with me here. It's the P wave, the Q, R, S, and T. Now the T wave here represents ventricular repolarization. If ventricular depolarization was propagation of the electrical impulse facilitating contraction, ventricular repolarization is resetting. We're preparing the cells for a subsequent contraction. They've just contracted, we're now resetting them, preparing for a next series of contraction. So you'll notice we have atrial depolarization, we have ventricular depolarization, we have ventricular repolarization, but if you said to yourself, something is missing, you'd be right. On this figure, you do not see atrial resetting, atrial repolarization. But don't worry, it's still there, you just don't see it. We refer to this as the TP wave. This represents atrial repolarization. However, you don't see it because the electrical activity generated by the ventricles, a much stronger myocardium, a much larger muscle mass, generates an electrical activity that covers up or shadows atrial repolarization. So because those two, ventricular depolarization and atrial repolarization, because the two occur at the same point in time, we don't usually see atrial repolarization. Now, to give you another structural point that you want to know, it'd be the J point. So if we know the P, the Q, R, S, T waveform, it's at the point where, and this S may have gone down and come back up, but it's the point where the end of the S meets up with the isoelectric line. And this point between the S and the T, or start of the T complex, is called the ST segment. Now it's at this J point where it's going to be important for us to better understand what's going on inside the heart. Because the J point may not be on the isoelectric line. We may refer to what's called J point elevation or J point depression. Now, sometimes the J point can be very sharp and clearly definable. Sometimes it's more diffuse, where we're not really sure where the J point starts and stops, because there's really no discernible ST segment. See, here we would say there's an ST segment, it's right here. It's that area of no electrical activity that occurred between the end of the QRS and the beginning of the T wave. In this case, if this was our isoelectric line, right here, where there's no electrical activity, this particular ST segment would be considered to be elevated. This ST segment is also elevated, but it's more diffuse. We're not really sure where that ST segment is. So we have in this figure representation of some sharp J points, whereas others in this figure also show diffuse J points. And so being able to isolate where this location is can tell us a lot about what's happening inside the heart. Present with you another example. So I talked about ST segment and some of the changes that occur. So here's our isoelectric line, and here's our ST segment. It's right along the isoelectric line. Here it is again, here it is again, here it is again. The ST segment's at baseline. Here, if this is our isoelectric line, here you see the ST segment is elevated. Here you see the ST segment is depressed. So we have some examples there of what that might look like. Now, what's that mean to us? If we're the clinician, we're looking at the ST segment. Well, it could mean a lot of different things, and it's going to, I want to be very careful here. Just because you see something like this doesn't mean, that's exactly what it is. Not in all cases. Because looking at a single lead, a single waveform may not give you enough information about what's going on. That's why we have a 12 lead, to look at a lot of different waveforms, a lot of different perspective of the heart to better understand all the nuance and changes that are occurring. Because it could be something that just is an odd variant that is just occurring in a particular lead. Maybe it's because we did a poor job in placing the lead. Maybe it doesn't have good skin connection. the conductivity is poor. Maybe it's because we put it in the wrong spot. It's not getting a good signal or it's not getting a good picture of the heart because it's too high or too low. So be careful when we look at a single lead and a single rhythm about making these definitive declarations, because you really can't do that. You need a full perspective. But let's look at this. Okay, what might happen in some of these examples? ST segment shapes and possible causes. If we had, for instance, this early repolarization that occurs, whereas we're on our Q, R, and our S waveform, before it crosses the isoelectric line, we have this early beginning of the T wave. This could just be early repolarization. Maybe nothing. But it could also be pericarditis, and we might look at that along with the PR segment. We'll talk about that in a moment. So again, there might be a couple of things that we have to confirm. If I see one thing, I need to look for 1, 2, 3 other things to confirm. Okay, that's something when we look at an ECG rhythm, where our eyes are constantly scanning. We're looking all over the page, because if I see one thing, I want to know, okay, part 1 was met. Was part 2? Was part 3? Was part 4? Maybe that's this, right? So again, here you see maybe a strain pattern. Could be problematic, leading to something like an infarction. We'll talk about some of the progression that we may see. Here you have a very scary tombstone pattern. This is something that we're probably going to see in a lot of different leads, and it's going to look very clear. If we see this in a lot of different leads, think infarction, problem, cell death, right? Perhaps ventricular aneurysm. It kind of depends on other leads that we're looking at. Again, concave upward and with a little bit of ST segment elevation, a little strain pattern. Here we have some injury pattern where we don't have really that concave shape. We would also be wanting to look at, the T waves. Are they unilateral, or do they look rather uniform? Are they asymmetrical? Okay. So some things that we might also be considering. And then, some problems, maybe subendocardial ischemia. We might be looking at confirmation in other areas. Do we have reciprocal changes in other leads, which again confirm some of the things that we're seeing in one area. Okay, so let me shift gears and talk to you about calculating heart rate. This is actually something that's pretty cool, because you can do this with a single lead. You can calculate heart rate very quick. And after this, every time you look at an ECG rhythm, you should be able to very quickly identify, the heart rate is this. Now, I want to be careful. This is when we have a regular rate, meaning that all of the R waves are occurring with consistent intervals. If we have R waves that are occurring at random intervals, we can't really use this technique, because it would tell us something between one R wave might look like 300, and between another R wave it might look like 150, or it might look like 100, especially if we're missing certain patterns. Maybe we have some type of heart block, as an example. But let's assume we have a regular rate. There's a regular rhythm to the R waves. I want you to look and find an R wave that's on one of these dark lines. And if you find an R wave on a dark line, let's call that the starting point. We'll count 5 small boxes and we'll see another dark line. If the next R wave in your rhythm strip occurred on this line, that person's heart rate would be 300. That would mean we would see an R wave here, 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 we would see an R wave here. Very regular rhythm occurring every dark line gives us a heart rate of 300. If the next R wave one occurred here and the next one didn't occur until here, that would be a rate of 150, 100, 75, 60, 50, and so on. So let's practice what we've just learned. And let me put the figure from the previous slide up here as well. So this will kind of help you. So if you're looking at panel A, I want you to find an R wave that sits as close to 1 of the dark lines as possible. And then I want you to count over 300, 150, 100, 75, 60, and identify when the next R wave occurred. I want you to do the same thing for panel B. You can pause the video here, and then we'll go into some of our answers. Okay, so if you pause the video, welcome back. If you didn't pause the video, you're super fast, you already got it. So let's look at this one. This is kind of where my eyes are first drawn. I see this R wave occurring pretty close to this dark line. So I'd count over 300, 150, 175, 60. So that tells me that this heart rate is somewhere between 75 and 60. In this case, it looks like it might be, a little bit closer maybe to this 60. Somewhere maybe right in the center because this occurred a little bit after. So I'd say, we're looking at a heart rate here around 70 beats per minute, 68 beats per minute, somewhere pretty close to there. Now, if you said, I didn't use this one, I used this one, and I counted back this direction, that's fine too. Let's do that as well. 300, 150, 100, 75, 60. And you looked at that and you said, okay, it's somewhere right in the center. Now, this one occurred a little bit before this line. So, somewhere right about the same. Let's look at this one. This one right here, I saw that right away. 300, 150, 100, 75. This one occurs right on that line. 300, 150, 175. 300, 100, or 300, 150, 175. 300, 150, 100, 75. Okay, so in this case we have a regular rhythm. You could have used any one of these, gotten the same result. Okay, how about these? Go ahead and click your pause button. And welcome back. What do you got? What do you got? Well, we could use this one. That looks pretty close. You might be able to use this one. You could get away with that. You could probably get away with that. This one looks the closest of all of them. I'm going to count this direction. 300, 150, 100, 75. We're somewhere between 100 and 75. Maybe somewhere around 90. 88 beats per minute. Let's go down to this one. This one right here. That caught my eye. So I could go in either direction, right? If this is a regular rhythm, it wouldn't matter. 300, 150, 100. We're somewhere right between 150 and 100. Let's call this 125. Now let's do the same thing. Let's go backward. 300, 150, 100. Again, somewhere between 100 and 150. So my example here would be, again, 125. Regular rate, regular rhythm. We can do this counting and math in that regard. So let's go forward here. We could also, in some cases, look at heart rates that are really small, which means sometimes they're going to be less than that 60, 50 of that chart that I previously showed. So by knowing the time interval, it can be useful for calculating bradycardic rhythms, ones that are really slow, less than 60 beats per minute. If you know that each of these tick marks is 3 seconds, that would mean 2 sets of tick marks is 6 seconds. So if you count the number of cycles present in a 6-second strip and just multiply by 10, that gives you the number of beats that occurred in 60 seconds. So if there was a spike here, a spike here, a spike here, and a spike here, 4 spikes in 6 seconds, that tells me this heart rate is 40. Or you could count the number of cycles in a 12-second strip and multiply by 5. Okay, either way, that works for slow heart rhythms. Okay, let's look at the P wave, right? Let's focus on the P wave here. Notice that the SA node generates the electrical activity. That electrical impulse propagates across the atria, and it makes its way and finds its way to the AV node. So when we talk about the generation of the P wave, this is all we're talking about. atrial depolarization. We're not concerned about what's happening down here. What's happening down here has nothing to do with the P wave. That all has to do with the QRS complex and the T wave. So let's look at some P wave morphology. Remember I said to you, depending on the lead that we're looking at, it's looking at the heart from a different direction. It's looking at the heart from a different direction. Now, in the case of lead 2, if we look at this electrical axis that's typically running this direction on the heart, lead 2 would typically be somewhere down here, where the negative and the positive pole would be down here. So if the electrical activity is propagating in this direction, it would be propagating toward, in Eindhoven's triangle, that hexaxial system, it would be propagating toward lead 2, so we would see a positive reflection. Something like B, where it's propagating in this direction here, might still be propagating toward lead 2, but maybe not quite as strong positive, because it's propagating toward lead 2, but maybe a little bit less, directly toward it, versus an electrical impulse. Now, A, B, and C I didn't mention. A, B, and C are just labeled beats originating from areas outside of the electrical conduction pathway. A would be the SA node, that'd be normal. If an electrical impulse generated from this location B or from this location C, these might be considered premature atrial contractions generating an electrical impulse from outside of the conduction pathway. Now, in the example of C, if the electrical impulse was started here and the electrical activity propagated this direction, and lead 2 is here, it's really going away from the positive lead, because if it's headed toward lead 2, it looks like this. It looks like this. If it's going away from lead 2, we now get more of a negative deflection. Okay? So let's take a look at some P wave morphology. Now, typically the P wave, in most cases, following a normal conduction pathway, tends to be positive in lead 1 and lead 2. We almost always see it positive in lead 1 and lead 2. And we almost always see it positive in lead 4, 5, and 6. Again, I said almost always we see it positive in lead 1, 2, 4, V4, V5, V6. Lead 1, lead 2, V4, V5, V6. It's almost always negative in AVR. Okay? Almost always negative in AVR. Now, in some cases, now we see it positive reflected in some of these other. In this one, look here. This, do you see how it's up and down? In this case, this is a biphasic P wave. Okay? This one's a biphasic P wave, meaning that its signal is perpendicular to V1. So, again, this can tell us a lot of different things about what's going on in the heart. The blue dots that we see here, these are just representing all the P waves that are occurring. So if a P wave is occurring here, that means if I follow up at the same point in time on all of these, I should see a P wave. So if I follow this one, there's my P wave, there's my P wave, there's my P wave. Now that's actually an important component to mention, because remember how I said if you look at one lead and you see something, you don't automatically make this robust conclusion. Let's say, for instance, the P wave was gone. I didn't see it right here. I might be thinking to myself, oh my gosh, I might have some type of heart block. Maybe the P wave's missing, the atrial conduction pathway is all screwed up. And I don't see it right here, and then I look down and I go, oh, there it is. Oh, there it is. Well, it's there. That lead just didn't pick it up. Or that lead has poor conduction. The skin wasn't prepped properly. Or that lead is in a wrong position, not able to see the electrical impulse activity from the atria. In addition, if I see a bunch of bumps, like this here, if I'm like, oh, is this a negative reflected P wave? Or what's this little bump here? I'm not really sure. I could go to one where I'm confident. This is definitely the P wave. And I'm going to follow this up and I say, oh, no, that was the P wave right here. because it occurs at the same point in time as this one down here. So a couple questions that you might ask yourself as you look at an ECG waveform. Do you see any P waves? Right? P waves indicate atrial supraventricular component of the heart. Are P waves missing throughout the ECG wave or throughout the 12 lead? Maybe we've got some issues with that atrial conduction pathway. Are all the P waves identical? Or are some of them, do some of them look different in morphology, especially in the same lead? Let's say if I look at lead 2, which is a 3-second component, and I've got multiple leads that look different in the same lead, multiple P waves that look different, that might tell me there might be some problem with the pacemaker, because now P waves might be generated outside the pacemaker. Maybe I want to look at that continuous lead strip along the bottom. Do all the P waves have identical PR intervals? Or are they gradually getting further and further apart, indicating there may be some type of problem? Are the P waves not identical? Two possible causes. Maybe we have additional pacemaker that's firing from somewhere outside the region, ectopic. Is there another component of the complex superimposed on the P wave? You know, for instance, the T and the P wave are occurring at the same point in time. Does the QRS complex have a P wave? A lot of times when we look at an ECG rhythm strip, we'll say, is there a P for every QRS, a QRS for every P? Did every P wave generate a QRS? And if we see a QRS, was there a preceding P wave? Because if there's not, abnormal number of P waves indicates possibly an AV nodal block. And is the PR interval constant? Again, if it's elongating, if it's changing, right, this is going to tell me what type of block may be present. Here's some examples of irregular rhythms. They're irregular, but they're regular, you know, they're maybe occurring all in random intervals. This one is atrial fibrillation. We have a bunch of P waves being generated. Now, these are all three different, so don't look up like we normally have, but these one rhythm strip. Do you see a bunch of bumps here? All of these P waves are occurring. There's a P wave, 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 then a P wave and a QRS. A P wave, a P wave, a P wave, then a P wave and a QRS. We're in atrial fibrillation. The atria is contracting, 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 contracting. And then the signal is making its way to the ventricles. Wandering atrial pacemaker. Again, do you remember I said in a single strip, a single rhythm, we look at all the P waves. Do they all look identical? Look here. Do you see this one is rather peaked? This one is a little bit more plateaued or flat. This one's really flat. This one's really small compared to that one. All of these P waves look a little bit different. This tells me that there's an electrical impulse coming from outside of the normal area. And then, you know, if I wanted to say what is my rhythm or what's my rate here, maybe we have a fast rate. Or if we look at all these and we count a 3-second or a 6-second strip, and we look at all the P waves, that one's different from that one's different from that one, it's different from that one. Nope, these two look very similar, and these two look very similar. This one looks different. So there might be 3 different types of P wave in tachycardia. So we would call that multifocal atrial tachycardia, telling me the atria is generating a signal from a different location. Here's an example of wandering atrial pacemaker. We'd break this down into pieces. So we'd start with our analysis. Do the P waves all look alike? Are all of the PR intervals the same? Look at this area with the star. We have a really large T wave superimposed on a P wave. Can you see the P wave? The T and the P are occurring at the same time. So that created a rather large waveform. So look at this lead 2. This is a continuous strip. Look at all the P waves here. See this one? See this one? Ooh, look at that one. That one's really small. See that one? Look at that one. Look at that one. They all look very different, right? They all look very different. So again, wandering atrial pacemaker. The pacemaker for the heart is all over the board. Now look here. Do you see this example? I don't see any P waves here. And if I saw only this strip, I might be led to believe that the atria is not participating in this activity. But if I quickly look down the row, I see, oh no, there is a P wave. I just don't see it here. That's okay. I just don't see it in that one. So a couple things that we want to keep in mind as we're looking at a rhythm strip. Now here's another unique thing. This is called P mitral, something that we look at with the P wave. P mitral is much like an M-shaped P wave, and it typically occurs in the limb leads. And what's unique about this particular structure, mostly it occurs in leads 1 and 2, is that it's really wide. That's 3 small boxes, 0.12 seconds, because here's 0.04, 0.04, 0.04. 3 small boxes wide. And then we have this bimodal hump. And the hump, if we measure from the top of this peak to the top of this peak, is 1 box wide. So the notching here is caused by prolonged conduction times required to transmit the impulse through an enlarged left atrium. So when we see this particular notching, then it may be very clear to us, perhaps this person has severe left atrial enlargement. If they have left atrial enlargement, remember that discussion about, think about the system in reverse? Things that happened before, right, if we're going in reverse. So let's take hypertension. That's in the systemic. Go in reverse. Where's blood go backward from the systemic circuit? Backward, it goes into the left ventricle. So we might have left ventricular hypertrophy in this patient as well. Because left ventricular hypertrophy has to generate a lot of muscle mass to pump out against a hypertensive patient, high afterload, so the left ventricle starts to enlarge. And what's the backup there? Well, the backup there is to the left atria. So now we're looking at left atrial enlargement as a result of hypertension, which caused left ventricular hypertrophy, which led to left atrial enlargement. What's one of the concerns that I have? That backup is going to lead to the lungs, pulmonary hypertension. Oh no, that's going to lead to some cause of backup into the right side. Now I'm looking at a patient with right ventricular hypertrophy and right side heart failure. And now I have a problem where I have the backup going into the right atria. And now I have right atrial enlargement, and now I have a backup providing some congestion in the systemic. And now I'm looking at congestive heart failure. All because of that pesky hypertension. That doesn't occur quite as fast as I indicated it does, but it does occur in a very similar manner. So P mitral is one thing. Just looking at the P wave, look at this. Oh, look at the P wave. There it is. There it is. Textbook example of P mitral. Textbook example of P mitral. Look at this. I haven't talked about this yet. Do you see this really large waveform here? Folks, we're looking at somebody with left ventricular hypertrophy who also has left atrial enlargement. Do you see this? I see one thing and I go, oh, let me see if this is present. Oh, there it is. So I saw one thing here. I look over here. I saw that. Oh, look at this. There's a biphasic P wave. This might also confirm for me, and we'll, be able to talk about some of the criteria. But this biphasic P wave here, I look over here. I have some indicators that now I'm starting to see 2 or 3 things similar, and I go, that maybe is what's going on. Folks, I may have never met this patient, and I may look at this and I go, does this patient have hypertension? Does this patient come in with a headache? Does this patient have some issues with... I haven't even seen this patient, and I'm looking at this and I'm starting to get a clinical picture of who this person is. Or maybe before I set up this 12 lead, the patient told me this is what's going on. And I started in my mind thinking, okay, what might the ECG look like? What am I wanting to confirm? Then I set up a 12 lead and I go, oh, look at this, look at this, look at this. That all matches some of these symptoms that this patient's having. Folks, the ECG is fascinating. The ECG is fascinating. Look at this, causes of left atrial enlargement. Remember that system in reverse? Remember that system in reverse? Problems here? Anything that obstructs forward flow, like hypertension, like arteriosclerosis, like atherosclerosis, like a narrowed vessel causing resistance to forward flow. Ooh, let's go follow the system in reverse. We're now in the left ventricle. The left ventricle, because of hypertension, the left ventricle is failing. Now that causes a backup. That causes increased forward pressure for the left atria. Now the left atria has to try to pump against all this congestion here that's in the left ventricle. So the left atria now begins to enlarge. What if we had mitral valve disease? Could you imagine if this mitral valve had problems with allowing blood through it? That says, the atria has to work a little bit harder. Right? So systemic hypertension, aortic or mitral valve disease, where we have problems with blood flow through the heart, restrictive cardiomyopathy, left ventricular failure, anything that obstructs forward flow. Enlargement occurs when the muscle dilates in order to compensate for some of that additional blood volume that's not able to move out. Now let me give you this other one. This is another example here, P pulmonale. P pulmonale is a peaked, TP-shaped P wave. Typically it's taller than 2.5 millimeters high in a limb lead. Most commonly we'd look at limb leads 2 and 3. Classic finding here for severe right atrial enlargement. So when we have a peaked P wave, less than 2.5 millimeters high, that may not necessarily be associated with atrial enlargement. So if we see something that's peaked, but it's not really tall, maybe that's not atrial enlargement. But if it's something that's tall, what does that tall height tell you? It tells us about some of the challenge that this person's heart may have undergone because in some of the adaptation that has now occurred. So if you find P pulmonale, we might be looking at some other things. If you find P pulmonale and we look and see the axis deviation, we look and identify right axis deviation, we might also ask ourselves about some type of hemiblock, right? To identify, hey, is there P pulmonale with right side axis deviation? Well, maybe it's left posterior hemiblock is not diagnosed because the right side of disease is causing the axis to swing over that direction. So if I'm considering how the electrical axis moves and I see P pulmonale, it makes it very difficult to identify a left posterior hemiblock as a result. Right? So any findings that are consistent with right atrial or ventricular disease, might be kind of indicative on an ECG waveform. Let's look at some of the causes here of right atrial enlargement. Again, think about the system in reverse. Right? We're going in reverse. We're going this direction. We go into the left atria and the left ventricle and the left atria, and then we get to the lungs. What if we had a patient with COPD, problem in the lungs? And we move that system in reverse. Creates some challenges in the right ventricle. Creates some challenges in the right atria. So a patient with right atrial enlargement, P pulmonale, I might be thinking to myself, gosh, what's the cause of that right atrial enlargement? Does that patient have any lung challenges? COPD, pulmonary emboli, pulmonary hypertension? Might go all the way into the left side. Maybe a mitral valve disease or outflow problem causes the problem. Maybe it's at the tricuspid valve, right away, right here, causing some of the challenge to outflow from the right atrium, moving blood into the right ventricle. So when I see some of these indications, I look and I go across the board, how does this ECG look? But then also talking to the patient, right? If I see something, this leads me to ask more questions. I have an indicator on an electrical impulse or an electrical activity of the heart. Do I see anything clinically in my patient? Because maybe nothing matches up. Maybe they're asymptomatic. Maybe this is nothing. Maybe it's not a big deal, but maybe it is. Maybe we need to ask those questions. Do you see here? Do you see this P wave? Really tall. My goodness. Look at that. This is lead 2, right? Commonly in lead 2 and lead 3. Oh, look at that one. Lead 3. Whew, look at those P waves. They almost look like the QRS complex. They almost look like the QRS complex, but they're not, because the QRS complex is right after it. These are huge P waves. My goodness. Look at this. Huh. Might see some right ventricular or left ventricular hypertrophy in this one. Huh. A lot of different things was going on, and this is kind of my eyes are scanning. This is why we get a lot of different confirmation from different areas. The PR interval, let's move to this. So this is kind of this P wave. So from the start of the P wave to the start of the QRS complex, this is the PR interval. If I use this term PR segment, I'm talking about the end of the P wave to the beginning of the QRS complex. So this would be a PR segment. This would be a PR interval. Okay. So this is the PR interval. It relates to the electrical conduction system and representing its location, right, as we have this propagation of the electrical impulse and pause of that impulse at the AV node bundle of His. So this dashed component that you see here, labeled AV, represents a slowed conduction that starts in that AV node bundle of His. That's what we see happening here. So look at my PR segment. Okay, if this is the PR interval from start of P wave to start of QRS, PR segment's right here. PR segment's right here. PR segment's right here. The PR segment should be on the baseline. That is on a line drawn from this isoelectric. If the PR segment falls below the baseline, it's depressed. Here it would be elevated. So when there's a gain of a few milliseconds, a shorter PR interval, origin of the P wave is near the AV node. Okay, if we have a shortened PR segment, might give me some indication of what's going on in terms of where that impulse is beginning. If there's a loss of a few milliseconds, in other words, a longer PR interval, that could be an ectopic beat transmitted from a cell that's a little bit further from this internodal pathway, from this PR or the AV node. So based on the length of the PR segment, based on the length of the PR interval, gives me an idea of where the beat may be originating. And we might have some changes in the PR segment, elevated or depressed. So the differential diagnosis here of a PR depression includes a normal variant. Could be, right? Let's look at the other regions, other leads. Let's look at the patient. Could also be pericardium of the fibrous sac that encircles the heart is inflamed. Pericarditis, the inflammation of that pericardium. Is the patient presenting with chest pain? Have they had any condition change in the last couple weeks, days, months? Typically, if we do have pericarditis, the depression that we see, a lot of times it's going to be diffuse, changing in most leads, most all leads. And if we have a normal variant, right, if the depression is less than 0.08 millimeters, that may not be a big deal. If the depression is greater than 0.08, then I might start to think, okay, maybe this is something like pericarditis. Atrial infarction, there's some other things that we can look at. We'll talk about some different indicators as we go along. But electrocardiographic signs here of pericarditis might be something like, again, looking for multiple things. Do I see PR depression and tachycardia? Do I see something like notching? This is characteristic that occurs, or is it more of a clean swoop type transition between the QRS segment and the T wave, right? Because I might see ST segment elevation, which is concave, scooped out appearance, and there's also notching at this terminal portion of the QRS complex. Look at this, especially in the lateral precordial leads. I might be looking specifically at V5 and V6. Look here. Here's V5. Here's V6. Here's a notching that's occurring. I also see some notching here and some notching here. I see some PR depression, PR depression, PR depression. Hard to tell here. Hard to tell here. But I've got some indicators to me here. I can tell there's PR depression. That's definitely PR depression. There's some notching. So this gives me an example, right? Remember, for acute pericarditis, we might be looking at these diffuse ST segment elevations, scooped and upwardly concave, PR depression, notching the S wave, tachycardia. In fact, it looks like all these are occurring and at a similar rate. So if we looked at this and we said 300, 150, 100, pretty close to a rate of 100, a little bit less, so it's not quite tachycardia in terms of a textbook definition. And again, you know, it's something that we're going to want to look at in multiple leads. We're getting pretty close there to meeting all these criteria, so I'm starting to get a hunch. So what can the QRS complex tell us? Well, the QRS complex says a lot, right? If we look at it from our limb leads, okay, here's lead 2, so anything traveling in this direction is going to be upward reflected in limb lead 2. If it's traveling in this direction away from it, then it's going to be negatively reflected in lead 2. If we're looking at the precordial leads, these are the ones surrounding the heart, giving us an aspect or positioning of the transverse plane. We're going to look at a lot of different things in the QRS complex. And folks, don't get bogged down by the large number of things that we're discussing, because gosh, there's, you know, this EKG would be multiple semester class, multiple lectures, a lot of different, but these are some of the bullets, some of the highlights. But we're going to look for a lot of different things with the QRS complex, and each of these is going to tell me something different. So let's look at height or amplitude of the QRS complex. Let's look at the width and duration. Let's look at the morphology. How does the QRS complex look? Does it have a single peak? Does it have multiple peaks? Maybe I'm looking at a bundle branch block. Presence of Q waves. Are they really large Q waves? I could fit almost a whole small box inside of one of the Q waves. Maybe I'm looking at somebody that had a heart attack previously. I'm going to look at the axis along the frontal plane. I want to know, do I have normal axis? Do I have right axis deviation, left axis deviation? Again, if I see something like that, I'm going to start looking for some other indicators. And what's the transition zone? This would be the z-axis, how, you know, I might be able to indicate, okay, maybe this person has some type of hemiblock or some type of reason that axis would be moving into early transition or late transition, for instance. And that specifically with 6, we won't cover this, but gets into some of our precordial leads, V1 to V6, and where we have a transition occur. Gives me some indication as to what's going on inside the heart. So if I'm looking at the height, right, my main component here is looking at the height of the QRS complex, the size, the direction of the vectors. Because the size of the vector is generated because of the size of the myocardium. A larger, stronger contracting myocardium generates a larger electrical impulse. If we think about EMG, electromyography, we're looking at strength of an EMG signal on a contracting muscle. The more electrical activity typically is reflecting more muscle contraction or more motor unit recruitment. So the size and direction of the vectors are the main cause of the change in the QRS height. Here, in this example, of an ECG wave pattern. Now, if the left ventricle is enlarged, hypertrophied, then we might have really large QRS complexes in some of our leads. If the amplitude is really small, really compressed, that tells me something else. Because we could have changes where this would be normal pericardial fluid around the heart, but because of an increase in pericardial fluid, or let's call this pericardial effusion, now when I look at this waveform, the QRS complex is depressed. So localized pleural effusion can cause changes in voltage as well as pericardial effusion. Obese patients, increasing the amount of subcutaneous tissue means that the electrode, the physical lead, is further from the heart because of the fat mass that's in between it. So obese patients may also have smaller voltages due to excess adipose tissue. Such things like amyloid deposits in hypothyroid patients may cause smaller voltages. Typically, men will have larger amplitude than women. Young people may have higher voltages in the limb leads because those electrodes are closer to the heart, or excuse me, precordial leads. Precordials may have a higher voltage because the precordials, remember, those are the ones surrounding the heart. So those may have a larger voltage just due to proximity compared to the leads, the limb leads. So a lot of different things to consider when we're looking at the height of a QRS. I mean, gosh, when we look at this, it tells us so many things that are happening. Now, very tall complexes usually are indicating hypertrophy of one or both ventricles, or perhaps there's an abnormal pacer. Something that's occurring outside the normal conduction pathway could cause a rather large beat, aberrantly conducted beat coming from somewhere that's outside of this normal conduction pathway and facilitating this pattern that looks very atypical. In this case, here we have a premature ventricular contraction where there's no associated P wave. So again, I'm looking at P waves. When I first start my assessment, is there a P for every QRS, a QRS for every P? No. Okay, this one's different. There was no P wave that occurred, but all of a sudden the ventricles decided we're going to contract, and they did. And they generated this rather large looking complex. So it gives me an indication something's going on in the ventricles, right? Is this of concern? Well, I don't know. How frequent is this occurring? I need to look at maybe a minute of time. Did I have a lot of these PVCs occur? More than 8? Less than 8? Did any of them occur in subsequent fashion? A run of 3 might indicate ventricular tachycardia. PVC, 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 all in a row, right? This might give me a little bit more pause for concern than a random one that occurs every 20, 30, 40 seconds. So we look at amplitude, and we've talked about voltage. I talked about limb leads. So criteria for abnormally small, and you know, I mentioned, okay, if a lead is small, okay, now here's the answer. Well, what does that mean? Well, it would be a voltage that's less than 5 millimeters in the limb leads and less than 10 millimeters in the precordials would be considered abnormally small. So things to keep in mind: a person who's thin, right? Person who's thin would typically have a larger precordial, but let's say a thin person with some type of effusion, they may have larger precordials than somebody who's, you know, more overweight with an effusion. So again, we may not see the same manifestation given the person's morphology, the body size, because two components may be competing. So we want to take into consideration a lot of different things. So with left ventricular hypertrophy, we have a hypertrophied, enlarged left ventricle caused by, I mentioned this a number of times, we'll talk about it just ever so briefly right now, outflow problems, pressure overload. Basically, it's harder to pump against this afterload, this resistance, so high aortic or arterial blood pressure, stenosed aortic valve. Is there a volume or dilation problem? The heart has to pump a little bit harder to get the blood out. Okay, confronted with a harder workload, it's like any other muscle, the heart becomes larger to adapt and overcome. Enlarged too much, we may end up with hypertrophic cardiomyopathy, a poorly performing left ventricle. So the more mass or cells in the heart give larger action potentials, or causing larger action potentials picked up by the ECG waveform. And these larger vectors have a greater increase in amplitude. And the increase in amplitude in the precordials is because we're so close to the electrodes in the chest wall. So a larger left ventricle pushes the heart typically forward closer to the electrodes to begin with, again producing a larger complex. So not only, this is especially true with left ventricular hypertrophy and larger muscle mass, but not only because the electrodes are closer, but as I mentioned, because it pushes it forward toward the chest wall. And we have some criteria for diagnostic. When I mentioned on some of the other slides, I said, oh, it looks like we might have left ventricular hypertrophy here. We're counting a number of different things. We're looking at different leads. We're looking at the S wave in V1 or 2, or any precordial for that matter that's greater than 45. But if we just look at V1 or V2, and we add that with V5 and V6, is it greater than 35? Or a single that's greater than 45. If I look at the R wave in AVL, the R wave in lead 1 being greater than 12, the R wave in AVF greater than 20, all these indications. Now note, these criteria don't apply if the electrical conduction doesn't go through the normal pathway. If it's an aberrant rhythm or something occurring outside the pathway, I can't look at one of those really large, odd-looking complexes, like I mentioned in a slide a moment ago with a premature ventricular contraction. But if it's a normal pathway, then yeah, these criteria apply. Now remember, on the next slide, we're going to look at this criteria here. So if I look at leads 1 and 2, and I count the number of millimeters, and I add that whichever is greatest in 1 or 2, and whichever is greatest in 5 and 6, and I add those up, are they greater than 35? So I look at V1 and V2, and I count the number of boxes in V1, and I count the number of boxes in V2. Looks like V2 is bigger. Let's just say that's 25. I count the number of boxes in V5, and I count the number of boxes in V6. Oh, looks like V5 is greater. So I take 25 plus 13.5. Is that greater than 35? Yes, it is. This would be meeting criteria, again, for left ventricular hypertrophy. Right ventricular hypertrophy, enlargement usually seen in the right ventricle when pressure overload, because of pulmonary hypertension or multiple pulmonary emboli or pulmonary scarring that can occur. So a lot of different reasons there that we might have right ventricular hypertrophy. And again, we have criteria to identify right ventricular hypertrophy on an ECG. The RS ratio typically in V1 and V2 are going to be typically less than 1, because typically this is downward reflected. But in right ventricular hypertrophy, this tends to point upward. And in that case, it gives us an indication that the RS ratio, in other words, this part, which would be 10 boxes, and this part, which would be 4 boxes, so 10 divided by 4, is that greater than 1? Sure is. That tells me that this meeting criteria for right ventricular hypertrophy. We might also look at P pulmonale, right atrial enlargement. Remember looking over to see if lead 2 and 3 have a peaked P wave, because that's going to be another helpful criteria. I might look at right axis deviation. I might look for right ventricular strain, or right ventricular hypertrophy and strain pattern. And I might also look at S1Q3 T3. Now a large S wave, this is a large S wave in lead 1, a Q wave present in lead 3, and T3 refers to an inverted or upside down T wave in lead 3. Now together, these could indicate acute right heart strain, and it also may be a pattern that precedes diagnosis of pulmonary embolism. So again, we see the three of these together, we might be looking at some indication of some different things. Now, a moment ago, I mentioned right ventricular hypertrophy strain pattern. Strain pattern would be what? Well, it'd be an increased RS ratio, ST segment depression, concave downward, flipped, asymmetric T wave, right? All the above. So let's look at right ventricular hypertrophy or criteria. Again, let's see, is there an RS ratio, let's say in lead 1, or V1 and V2, that's greater than 1? Yeah, right here. But, it doesn't have to happen in both. So this is another thing. We need to consider our criteria, and we say it doesn't have to have all the criteria from lead 1, V1 and V2, but in this case, V1 certainly has an RS ratio greater than 1. Now, there's also flipped T waves, okay, associated with some of that strain pattern, concave, so I might be looking at some other consistent variables on this particular ECG consistent with right ventricular strain. Some other things that might cause, though, an increased RS ratio. So again, just because it happens doesn't necessarily mean that that's the one thing that it is, because there are other things that may cause an increased RS ratio in V1 and V2. For instance, in addition to right ventricular hypertrophy, we might also see right bundle branch block. Now, in a right bundle branch block, we may have more of an M-shaped pattern, or kind of this two peaks of our R wave. It may also occur in young children and adolescents as a normal variant. It may occur in the instance of Wolff-Parkinson-White syndrome, which is what's being reflected here, where there's a scooping type slurred delta wave, okay, as opposed to this QR nice normal pattern, but this delta wave is this sloping transition. That would be characteristic of Wolff-Parkinson-White. Or if the patient had posterior wall myocardial infarction. Okay. Now, of note, we won't go into detail here or show examples, but there are 3 types of Wolff-Parkinson-White that may be present: Type A, Type B, Type C. Type A is where a QRS is mainly upright in all your precordial leads, and this would tell a clinician that the pathway, which is called the Kent bundle, and in fact I've got a picture of it right here, it would say that the Kent bundle is on the right side of the heart. Excuse me, the Kent bundle is on the left side, just like this one. This would be a normal variant. So the Kent bundle is on the left side of the heart, as we're seeing right here. This would be Wolff-Parkinson-White type A. Now, in Wolff-Parkinson-White type B, this QRS complex, we're still going to see this slurred R wave. However, it's going to be negative in V1 and V2. And when that's the case, the Kent bundle, which we see right here, actually might be over on this side of the heart. The Kent bundle may be on the right side of the heart. And the problem here is, sometimes we can mistake this for some type of left bundle branch block, but again, we need to be conscious and conscientious that we need to look for other signs and symptoms and other indicators of what's going on. Type C is really rare. Typically, the QRS is upright in V1 through 4 and negative in V5 and 6, just as an example. But that typically type C, Wolff-Parkinson-White, is not as common. Okay, so kind of in closing, we could go with a whole lecture on ECG progression in infarct. That's the honest truth. So we're just going to show a very quick understanding of myocardial infarction. So the ECG pattern in acute myocardial infarction are not really a static picture, but rather a continuum. Okay, so here nothing is wrong, and over time ischemia develops, and we see this gradual progression. In other words, if we took an ECG at minute 1, where the person says, "Yeah, I kind of feel odd, I feel a little chest pain," we take a picture of the heart. I say picture of the heart, but I really mean a picture of the electrical activity on an ECG, and we see something like this. 10 minutes later, the patient goes, "Gosh, I feel this crushing chest pain. It feels horrible." We take another ECG image. We start to see something like this. Really scary, right? So the first thing that happens is typically the T wave flips. This happens in early ischemia, right? Reduced oxygenation to the tissue. And then there's the ST elevation that accompanies the flip T wave. We start to see ST elevation with flip T wave. For a short period of time, we'll be in this stage. And finally, we start to see these Q waves that start to develop. You see these more robust Q waves, and it's really tombstone-shaped ST elevation. So this obviously is a problem if we start to see these tombstone-shaped indicators. And again, when we begin to look at the regions where this is occurring, this figure comes back to mind. Now, some people call this leasal. Leasal. They use this term to remember L for lateral, I for inferior, Li, leasal, S, A, V3, V4, L. So I'd say leasal. This is my L, I, S, A, L. So sometimes you'll hear people say, let's look at leasal, meaning let's find the infarct regions, where in the heart is it occurring. If we have something that's occurring only in lead 2, 3 AVF, pretty good indicator, inferior. Something that's occurring in V1, V2, septal. Sometimes you'll see anteroseptal, V1, V2, V3, and V4, anteroseptal gray, MI, something along those lines. So why is that important? Well, here's why it's important. Because we have main arteries perfusing certain areas. So if we see a problem in 2, 3, and AVF, this tells me it's an inferior region of the heart. Maybe the right coronary artery or the left circumflex is impacted by this particular ailment. If I look at the anterior perspective, maybe it's the left anterior descending. If it's something that's like anterolateral, inferolateral, posterolateral, left circumflex, right? So depending on the region that I see impacted when I look at the 12 lead, gives me, or the cardiologist, an idea of the region of heart which is impacted. And just as one example, and we could do hundreds of these, we could do them, step by step, saying this is what it looks like with inferior, this is what it looks like with, septal, this is what it looks like with anterior, this is what it looks like with lateral. I just want to show you one example here and say, here's an example, here's an example of an anteroseptal acute myocardial infarction with lateral extension. In other words, I've gone very complex and I've said, here's one that's hitting a lot. Here's one that's hitting a lot of regions. It's not just 2 or 3 areas. It's almost all over the board. This is scary. Anteroseptal acute myocardial infarction with lateral extension looks a little bit like this. So we'd look at this and we'd say, initially, when you first look at this, hopefully your eyes were immediately drawn right here. You go, oh my gosh, look at that. That's classic tombstone. Okay, what's involved here? Oh, okay, well, V1 and V2 are involved. ST segment elevation, yep, so that would mean it's septal. Okay, we have a septal MI. Oh, but look, we have also V3 and V4. Oh, those are also elevated, and it looks like we've got some tombstone. Oh, so it's anteroseptal. Got it. Oh, wait a minute. Okay, wait, look. It's also with lateral extension. Look over here. Oh, yeah, look. See, we have some elevation here. It's high lateral, in fact. We have some extension here. So we have an anteroseptal MI with lateral extension or high lateral extension in this particular example. Now, one thing that you'll also see is reciprocal changes. So sometimes, and we haven't talked anything about identifying these in large spectrum, but you'll also see one thing and you'll look for reciprocal changes. In other words, if I see a change, I'm going to look to other areas of the heart to say, is there a reciprocal change? In this case, I see elevation here. I'm going to see depression that happens here, right? So lateral, we might also see these, depressive segments in the ST segment. So a lot of different things that can occur. Just as an example there with identifying acute myocardial infarction, but when you see tombstones, not good. And so identifying location, might give the cardiologist an idea of what area the heart is impacted. So we'll conclude there, but please understand, gosh, there's so much more that could be discussed in terms of EKG and identification. And so I don't want anybody to think as they walk away from this going, I can look at a 12 lead and I can identify the ailments and the pathology just from this lecture. That is not the intention of this lecture. That is not the hope that I had for you walking away, but rather just to give you some things to, when you hear people talk about an ECG or when you hear a clinician speak about an ECG, it just gives you a little bit more perspective that you can understand a little bit more of the language. Okay. Now, we didn't talk about a lot of different components, but give you a very good highlight, and I hope that it was well received. So again, we'll conclude here. Thank you so much for your attention.